A very good afternoon to all, and we have no financial interest on this 7-year report of postoperative outcomes of IOL implantation in the bag and anterior vitrectomy versus optic capture of IOL without anterior vitrectomy in children below 4 years of age, a randomized clinical trial. Now, we all understand that performing anterior vitrectomy and anterior and posterior capsulotomies and then putting the lens in the bag is the standard of care for most children below the age of 5 or 6 years. Now, what if we can avoid this anterior vitrectomy? So we wanted to look at in the bag IOL and anterior vitrectomy as a standard method and optic capture of an in the bag IOL without performing anterior vitrectomy, and all this makes sense only in the long term. This was a prospective randomized control trial we started several years back in Ahmedabad. 61 eyes of children with congenital cataracts below the age of 4 years without any anomalies were included. Now there were two groups, 61 eyes randomized to group 1, where like I said, anterior posterior capsulorhexis manual with limbal anterior vitrectomy and in the bag 3-piece hydrophobic acrylic IOL. In the group 2, everything else was the same except for two differences. One, a 3-piece IOL, the same one was placed in the bag, and then the optic was captured behind the posterior capsulorhexis and no anterior vitrectomy was performed in a planned manner. A standardized technique was followed and a 3-piece hydrophobic acrylic IOL was done. Standardized follow-ups including EUAs whenever were necessary were taken, and this report includes at least 84 months of follow-up for all eyes. What we were actually looking for, basically three things: visual axis obscuration, VAO, which needed intervention within this 7-year follow-up, glaucoma as well as inflammation assessed in form of cell deposits, and posterior synechiae. So when we look at the preoperative demographics, we had 30 and 31 eyes in each group. The mean age in both groups was, in one group was about 18 and the other was about 15. But it's important to note that in both groups, about 45% eyes were below the age of 1 year at the time of surgery. The mean follow-up in this cohort was 95 months, and both had about a similar follow-up. But what I do want to highlight, that with free follow-ups, with so many calls, with no charging, still at least 25% eyes in both groups could not finish the 7-year follow-up. When we looked at intraoperatively, in 3 eyes out of the 31, we could not do a capture, and in 2 of these we had to perform a vitrectomy because there was an inadvertent rupture of the anterior vitreous face. Looking at the postoperative outcomes, in both groups there was at final follow-up, there was a good improvement, 0.6 logmar on distance visual acuity and not significantly different. When we look at how many eyes needed a procedure for visual axis obscuration, in the bag and vitrectomy 3 eyes versus no vitrectomy and capture group 2 eyes. Comparable, but what I'm saying is there is no difference. And all the eyes that needed vitrectomy in both groups were typically within 2.5 to 3 years of surgery. After that, none of them have needed a secondary procedure. When we look again below 1 year and above 1 year, you see that it's pretty comparable and there is no statistical difference. So it really doesn't matter in that sense. When we looked at glaucoma through these 84 months of follow-up, we found that the incidence of glaucoma was 2 eyes below the age of 1 year in vitrectomy group and only 1 eye above the age of 1 year, but again no statistical significance. So I think what I want to say is that I understand that this is a very skill-dependent procedure, and all credit goes to Professor Dr. Howard Gimbel for teaching us this procedure. And I think below the age of 6 months it's particularly difficult to perform, having an equally sized anterior posterior capsulorhexis and then being able to capture the lens. But above that, I think wherever you can, let's say between 1 to 6 years of age, if you can do a good anterior posterior rhexis and capture the optic, you are able to avoid anterior vitrectomy and yet get equivalent outcomes. We are not saying superior or inferior, you can have the same outcomes. And I think the other important point is, despite all our best efforts, loss to follow-up in the long term is a reality we all need, and I think this can be considered as a paradigm shift for performing a technique or a paradigm for performing surgery below the age of 5 or 6 years. And I do strongly recommend that wherever possible, all of us should consider optic capture of IOL to avoid an additional procedure whose long-term side effects, vitrectomy, we don't know yet in these small eyes. Thank you.
Thank you, Dr. Vaishali. As we all know, pediatric cataract is a challenging situation. Every case makes you feel this way or that way. I would again request Dr. Mahipal to share his experience as he himself is a star IOL surgeon.
Just one question, two questions, Dr. Vaishali. Was the IOL common in all?
Yes, the same three-piece hydrophobic acrylic IOL.
Same three.
Same.
Okay, and would you find any difference between the children younger, maybe less than 1 year? Yours was up to 4 years?
Yes, from 0 to 4 years.
So basically, there is a lot of difference between you put a lens even at 1 month, 2 months.
No, typically now in our new strategy, we don't operate children below the age of 6
Yeah, but
weeks.
your study said from 0
Yes,
to 4,
so-
so that's what I'm asking, because normally conventionally we don't put a lens below 1 year, at least I don't.
Sir, we put in any eye which has anatomically meets the criteria. A corneal diameter more than 10 millimeter, axial length more than 17, we will implant at any age.
Unlikely to be.
True, sir.
But VAO occurs in 100% of pediatric case. And there is no proof record that anterior vitrectomy has some complication. And in your study also, there was no statistical significance. So
Right.
why do you say that we are not supposed to? Because that's a gold standard till
So,
today.
I agree that till today we have been performing vitrectomy to
Yeah.
remove that additional scaffold for the lens epithelial cells. But when you perform an optic capture, because the anterior and posterior capsule leaflets are going to fuse, this will automatically confine the lens epithelial cells within the Sommering's ring and reduce, if not completely avoid, the migration into the center. And therefore, you may not need that additional procedure. And as for side effects of vitrectomy, yes, it's not proven, but Professor Stanley Chang from the US has shown in studies that vitrectomy changes the gradient of the oxygen free radicals and ascorbate levels, which may be a risk factor in causing glaucoma. Again, the other thing I also feel, which we are looking at in a longer data set, is the axial elongation in a vitrectomized versus a non-vitrectomized eye.
Yeah, that's important.
Thank you, Dr. Vaishali. We go
Thank
on
you,
to
sir.
the next speaker,